Happy Friday, everyone. Welcome to Preemie Chats. Preemie Chats is a program that is for healthcare professionals and parents to talk about what matters most to you, to explore new ideas, and to learn together. I'm Leah Whitehead. I'm the proud mom of a preemie and a former journalist, and I'm happy to be your host today from Halifax, Nova Scotia. Preemie Chats was created and is put on by the Canadian Premature Babies Foundation, also well known as CPBF. The foundation is a parent-led charitable organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, whether you're a healthcare professional or a family, I'd encourage you to head over to canadianpreemies.org. There you will find all kinds of free resources for yourself if you're a family, or that you can print off and use in your unit. You'll find the latest projects that we're working on, and most importantly, you'll find a community of people who want to see our little ones thrive. Today's session is live, so please bring your voice to the table. Leave your comments and questions in the chat, and we'll try to get to them at some point today during our program, because it is through rich conversations like what we're about to have where we can advance practice and learn together. So please participate. Let us know where you're watching from and your personal experiences. It's always good to hear that as well during Preemie Chats. One of the things that I learned as a NICU parent was just how vulnerable premature babies are. NICU parents have a heightened awareness of germs with all the hand washing and precautions in place during admission, and there's good reason for this. More so than term babies, premature babies are at risk for infection for several different reasons. Today, we're going to talk about those risks, but we're also going to talk about the importance of partnership in reducing those risks. Parents can be a key factor in keeping their babies safe, and we're going to talk about that today too. To lead us in the discussion, I'm happy to introduce you to Meghan Donohue. Meghan is currently a clinical educator for the Level 3 NICU at Sunnybrook Health Sciences Centre in Toronto. With over 20 years of NICU experience, Meghan's key areas of expertise are resuscitation, care of the acutely ill neonate, and perinatal palliative care and bereavement. Every time I talk to her, she brings a beautiful perspective of honor and respect when speaking of the relationship of parents and bedside staff in NICU. So I'm excited to hear what she has for us today. Thank you for joining us, Meghan.
Oh, thank you, Leah. That's such a lovely, no pressure, hey? Don't say such nice things before I've presented. I'm really pleased to be back here on Preemie Chats again today. Thank you so much for having me. So like Leah said, I have been doing this work for a long time. I think I'm in my 24th year as an NICU nurse and my 14th year working in the leadership team as an educator. And I still have the privilege of working with babies and families at the bedside as well. And so today we're going to have a conversation about preventing infection. And some of that is going to be as well discussing what we're actually talking about and why we care about these things, so that when we talk about the strategies we put in place to try to protect the babies, these things make sense to folks. Let's just make sure my slides are advancing, and they are. So here are some of the questions that we're going to answer today through our discussion. And really also thinking about that transition to home, because Leah's already alluded to the fact that we make you a little bit crazy about infection prevention and hand washing. And we have to be able to live in a world once your baby goes home where you can interact with people and have a full and joyous life. While still being mindful of the things that your particular baby might be at risk for based on their course in the hospital or any potential diagnoses they may have and things like that. So as we start this discussion, there's three really important things I want us to remember throughout this whole discussion. The first is that every single thing we do in the NICU has a potential benefit and a potential risk. Everything, even something as wonderfully positive as skin to skin care or kangaroo care has a potential risk. And that risk might be something like dislodging a breathing tube or losing an IV. That risk might be really, really small, but there is a risk involved in it. And we do the things we do because we have to believe that the benefit outweighs the potential risk. So that's the first thing, or the potential for harm. That's the first thing we have to remember. The second is that even if we do everything right, your healthcare providers do everything right, the institution your NICU's in does everything right, we have every protocol in place to prevent infection. You as parents and your families as visitors do everything we ask you to do and everything that's been proven to help prevent infection. Babies still can get sick, and particularly premature babies, because of a bunch of factors we're going to talk about in a minute. So if your baby has developed an infection, it doesn't necessarily mean something was missed. It doesn't mean a step was missed. It doesn't mean something was done wrong. It doesn't mean you missed something as a parent. It's just something that happens because of all of the things that they are at risk for. So, a lot of times, particularly as parents, we're really, really good at blaming ourselves for things. And that is never, ever going to be anyone's intention when discussing why your baby might have gotten sick. But also, I think as human beings, we're always looking for reasons, because if we can find a reason for something, then maybe next time we'll know how to prevent it. And sometimes we'll never be able to find the reason. So, that's another thing to remember. But the third, and this is probably the most important specifically for this talk today, is that while we're going to talk about the things that may increase the risk for infection and the things we can do to decrease the risk of infection, there are only so many things that we as human beings and you as parents can control. So I'm speaking about a factor that may not have been an option for you based on your situation, based on a choice you may have made, by a circumstance you may have been into. It's not my intention to make you feel like you didn't do enough, or you're not doing enough, or to feel guilty for the things that are outside of your control, or to regret choices that you may have made while your baby was in the hospital. So I will come back to this later, but I want you to remember that everything that happens while your baby's in the NICU, after discharge, whether your baby develops an infection or not, there's nothing that we're going to talk about here that is intended to lay blame on you or on your healthcare providers or on your institution or on your province or whatever guidelines there might be in place. It's really to make you just understand sometimes why things can happen. And then for those of us that are still in this position, or maybe ideally not in this position again, there are things that we can do that do decrease the risk. So, right off the bat, let's talk about what we mean when we're using the word infection. So, infection really is the invasion and the growth of germs inside the body. And when I say germs, germs are bacteria, viruses, fungi, parasites, but today I'm going to use the word germs to kind of encompass all of them. And some germs always cause a problem. Something like the flu virus or the COVID virus, that is going to make you sick. There is no reason to have that in your body for a good cause. So those things are what we call pathogens. But there are other germs that actually have a job and are perfectly fine and normal to have in certain places in our body or on our body, and they actually have a really good purpose. And as long as they stay in that place and they grow in the right amount, they don't cause a problem. We generally call those normal flora. And there's normal flora on our skin that has a really good job, a really important job. There's normal flora in our gut, in our intestines that have a really important job. And as long as those germs stay where they're supposed to stay, everything should be fine. So infection can happen when those normal flora or those good germs either overproduce or they get moved into an area of the body they're not supposed to be. So an example of that would be something like E. coli, which most of us have heard of in some form in the world. E. coli is a normal germ that lives in your intestines. It is really important for the digestion of food, and absorption of nutrients, and it's perfectly happy to stay and live in your gut. But when we get E. coli, for example, in our urinary tract, then we can end up with an E. coli UTI, and that can cause all sorts of problems for us. It's not supposed to be there. Same thing with the germs on our skin. That's why we clean the skin before somebody pokes you with a needle. We don't want to take those germs on the skin and introduce them into the bloodstream because they're not supposed to be in the bloodstream. So those are some of the things we have to think about as well. When we talk about infection, we can talk about localized infection. That's an infection that is limited to one spot in the body. It starts there and it stays there. So things like pink eye or pneumonia or a UTI, starts off generally as a localized infection. Now, or a cellulitis, which is an infection in the skin. A cut on your foot that gets infected would be considered a localized infection. Whereas systemic infections are infections that spread throughout the body and affect more than one organ or organ system. So, right off the bat, you might think, well, a localized infection is always going to be better, but that's not necessarily the case. The common cold would be considered a systemic infection because it affects multiple parts of your body, but generally speaking, it's not very serious. But a very seriously infected cut on your foot, which would be still a localized infection, could be much more troublesome than something like a systemic cold. We also know that a localized infection that isn't caught early enough or intervened on appropriately can become a systemic infection. And this is particularly important for our babies. So, our premature babies, with all of the risk factors that they have, particularly related from their immune system, a localized infection like a UTI, which we already know can make them very physically unwell, that bacteria can migrate into the bloodstream and the baby can have a systemic infection if we don't manage that UTI appropriately. Generally speaking, you and I, we have a nice robust immune system, and our immune system will protect our bloodstream from those localized infections, but our little babies don't have that benefit. When we have a systemic infection, the baby, let's talk specifically about our babies because that's why we're here. When our babies end up with a systemic infection, they become risk for something called sepsis. And we tend to use infection and sepsis sort of a little bit interchangeably in the NICU, but sepsis is really the body's overwhelming response to that systemic infection. It can cause excessive inflammation, tissue damage. The baby can go into organ failure. And generally, when we consider a premature baby to be septic, we would consider that when a baby has a positive blood culture, indicating the presence of bacteria or a fungal infection in the blood. If this sepsis continues and to progress and become more serious despite our interventions, then the baby could go into something called septic shock, which is when the organs no longer get enough blood flow, and with that blood flow comes your nutrients, your oxygen, your disposal of waste, and then those organs become damaged. And those are really our biggest concerns with our little babies when it comes to systemic infection. So, very quickly, and some of you may have experienced this in your time in the NICU, how do we diagnose infection? So, for our localized infection, if there are lesions on the skin, we would swab them. If you're thinking about something like chickenpox, where there's something visible on the skin, we would take a urine culture just like we would with an adult. We might take a sample from the baby's breathing tube. That's called an EDT aspirate, or a sputum test, or a big old swab up the nose like many of us had during the pandemic. Those are looking for localized infections. If we are concerned about a systemic infection, then we need to look at the systems that are sort of the way that infection travels through the body, and that generally is through blood. So a blood culture, and the little picture of the blood culture bottle down there may be familiar to some people. We would also do potentially viral blood tests. And then we may do something called a lumbar puncture. And that's where we take a sample of that fluid that bathes the brain and goes down the spinal cord, called cerebral spinal fluid, or CSF, and test that as well. So, why are our premature babies at risk? They're at risk for a few reasons. The number one reason, though, is their immune system is immature. When they are born early and haven't had the same length of time as their full-term friends to develop and mature, every organ system is affected. And so we know their lungs are immature, we know their brains are immature, we know their guts are immature, but their immune system is also immature. And for you and me, ideally, we have nice, robust immune systems. And those immune systems work by developing antibodies when they are exposed to germs. So we come in contact with something, our immune system mounts a response and sends fighters out to kill off those germs. And sometimes it works great, and you wouldn't even have known you've come in contact with something. Other times it doesn't work as great, and we get sick. So just because we have an immune system that's making antibodies doesn't mean we'll never get sick. But it means that our bodies recognize the germs and they mount a response. And ideally, what then happens is our immune system remembers those germs. So that particular germ that we came in contact with, that we mounted a response to, if I come in contact with that again in the future, my immune system already has that in its Rolodex to be like, oh, I know how to fight that guy. I'm going to go out and I'm going to take care of that, and you're not going to get sick. That's why some illnesses are kind of like a one and done, things like chickenpox, because once you've had chickenpox, you should have a nice immune response to that. Whereas if you come into contact with chickenpox again, you generally shouldn't get it. So our little babies are born before their immune system has fully developed. And what's really important to know is that the majority of the immune response matures in the third trimester, so 28 weeks and beyond. So if you are born before 28 weeks, you have very, very few protective mechanisms from an immune point of view. But that immune system, the majority of that foundation comes from 28 weeks and beyond, and for about another 2 to 3 months post-term, their immune system is still maturing. This happens because the maternal antibodies cross the placenta. So all of those germs that the mom has been exposed to, her nice, robust immune system is passing those antibodies across the placenta and starting to build that immune system in the baby. So when you're born early and you don't get that, those antibodies from that have already been developed, then we sort of need to have time for your own immune system to grow so that when you come in contact with things, you can produce your own antibodies. Antibodies also continue to be transferred through feeding. So this is really important as well from a human milk, breast milk point of view, especially in those first few weeks after birth. So this is why we consider premature babies to be immunocompromised. And when we talk about them being immunocompromised, it means they have the reduced ability to fight infection. And for these babies, it's because they have not received those antibodies and their immune system is immature. If you have someone, there's many other reasons you might be immunocompromised. You might have an autoimmune disease where your immune system doesn't work the way it's supposed to. You might be on medications that reduce your ability to fight off germs. So, for example, transplant patients, they're put on suppressants, medications that tell their immune system, hey, like back off, because otherwise the immune system would fight that new organ. Patients that are going through cancer treatment, there's a lot of different things that can make you immunocompromised. So, recognizing that these babies have this compromised immune system or this immature immune system, that's where this higher incidence of a localized infection becoming systemic comes into play. They aren't as good as we are at keeping that infection where it started. The ones we tend to see the most are an infection in the bowels getting into the blood, an infection in the urinary tract infection getting into the blood, or an infection in the blood, which is now already a systemic infection, potentially getting into that cerebral spinal fluid and causing an infection in that fluid that goes up around the brain. And we call that meningitis. So these are the things that we're really concerned about. And this is why it's very important that we identify problems and intervene as quickly as we can. So are there other risk factors? Absolutely. So the foundation is their immune system doesn't work very well. So we know that. They need time, they need to grow, they need to mature, and we need to support them through that. But what are the other things that put them at risk? Indwelling catheters. IVs, central lines, urinary catheters, umbilical catheters. These are the things that they need to get nutrition, to get medication, to get fluids. But anytime you have anything that breaks the skin or anything that is inside the body that's not supposed to be, it has a potential for infection. The second is invasive procedures like poking the skin for blood work, poking the skin to put those catheters in, surgeries, lumbar punctures. Any of these things that break the skin have the potential to introduce bacteria or germs into the body. A huge one for our very premature babies is immature skin. Our skin is our number one protector against the outside world. And we may, before I became a nurse and started doing this work, I didn't give skin a whole lot of thought. Our skin as adults have many, many, many layers. And it's nothing you can see, it's all sort of microscopic. But these layers develop over time as the skin matures. And so when you're born early, you are born missing layers of your skin. And so um, that complexity of the skin is what protects us. And so, as we are helping grow our babies once they've been born and helping them mature, the skin plays a huge role. So, this immature skin, first of all, doesn't have those layers to protect you, but also it's really, really prone to injury. And some of you may have experienced this if you've had a microprem where they're at risk for pressure sores. They might have a reaction to cleansing agents we're using to try to get the germs off the skin, before we poke them. They may have reactions to different adhesives that we use to keep monitoring or different lines in the baby. But when that skin breaks or breaks down because of its immaturity and because of injury, then that offers a portal for germs to get inside to the body and to cause all sorts of nasty problems. Just being in a hospital puts everybody at risk. So any patient, regardless of who you are at risk for infection if you're in a hospital, but particularly our preterm babies. Hospitals are notoriously germy places. And I'm sure, in your time in the NICU, you've seen how much cleaning happens. That's for a reason. But generally speaking, hospitals are germ factories. And so just being there puts the baby at risk. And then, of course, they're exposed to so many people as part of their healthcare team. And so we really want to make sure, we all carry these germs on our body. We've talked about that already. But also, we all live in a world where we might come in contact with things. So we want to make sure that we're paying attention to who we're exposing your baby to and to make sure those people are healthy. Not being allowed to eat. And when I say not being allowed to eat, I mean ingesting food. I don't necessarily mean orally eating. So being able to take milk through a feeding tube or by mouth if the baby is unwell and not able to eat, or if we're working up on feeds because the baby's very, very small and we're trying to get that volume of feed up into the baby so we can get rid of the IVs. Not eating puts them at a greater risk because the longer they don't eat, the longer they need those indwelling catheters. And that's really, really important to get those catheters out as soon as we can. On top of that, I've already touched on antibodies are transferred through breast milk. So if the baby is feeding breast milk and would be getting antibodies, those antibodies would play a role in protecting the baby. But if the baby's not allowed to eat because the baby's unwell or because the baby's gut is really immature and the baby's not tolerating, whatever the reason may be that we're not feeding, that lack of feeding increases the baby's risk of infection. There are really, really good reasons why babies shouldn't eat. So anytime your healthcare team is saying your baby's not allowed to eat, we don't do that lightly. It's for a very good reason. Again, that benefit versus potential benefit versus potential harm. But we do know it increases their risk of infection. And then the last one here is repetitive or prolonged use of antibiotics. And for some people, this might seem backwards. If antibiotics kill off the bacteria and make my baby better, why wouldn't we just give babies antibiotics all the time? And in the past, there was a little bit of a thought process of every preterm baby should get a course of antibiotics. Every preterm baby, anytime, antibiotics. If a little bit of antibiotics is good, then a lot of antibiotics must be better. And now we know that's not the case. So we know that when we give antibiotics, generally speaking, if we think a baby is sick, or if we're giving antibiotics because of a certain criteria, we give something called a broad spectrum antibiotic. And that antibiotic is going to attack everything. It's going to kill off a bunch of things. And then once we know if there's a particular bacteria that's causing the problem, we can change that antibiotic to be more specific for that bacteria. But at the beginning, we give a broad spectrum antibiotic. And that antibiotic will also potentially attack your normal flora, that good bacteria that's in your body. And so when we clear out the good bacteria, because they're just kind of coming along for the ride, like you're a bad guy and you're a bad guy. And oops, sorry, you were standing too close to him. So you're coming too, even though you're a good guy. We take away that natural defense that normal bacteria is going to do. So if we talk about that normal bacteria having a job to sort of tamp down bad bacteria, prolonged use or repetitive use of antibiotics can be a problem. There's something else that goes along with that, though. So actually, let's continue that thought process. There's a lot of chat in the world, like kind of I won't say like a buzzword, but people talking about the microbiome, a healthy microbiome. And a healthy microbiome basically means a healthy number of normal flora where they're supposed to be doing their very specific jobs. And so we want to protect that normal flora as much as we can. You may be familiar with someone being on a course of antibiotics and they develop a yeast infection, or they develop thrush, which is a yeast infection in their mouth. That's because the bacteria that normally keep yeast where it's supposed to be and the level it's supposed to be at get wiped out with the antibiotics, and the yeast goes crazy and has a party and overproduces and causes a problem. So, the other thing we need to know is that antibiotics only work against bacteria. So, if you have the flu or a cold, antibiotics aren't going to help you. They don't work on viruses. They don't work on fungal infections. They don't work on parasite infections. So, we have to be really, really thoughtful about when we're giving antibiotics. Antibiotics are really, really important, and we need to protect their use so that they continue to work the way they are supposed to work, because germs are also really, really smart and they can develop resistance to antibiotics. So if there's infection from a group of bacteria and the antibiotics are given, but let's say a few of those germs survive the antibiotic treatment, they remember the antibiotic and they're able to mutate and develop a defense against that antibiotic. And this is why it's so important that anytime someone is given a prescription for antibiotics, that they take the whole thing. And usually your pharmacist will tell you that, or your physician will tell you that make sure you take all 10 days worth of antibiotics, even if you're feeling better, because that little bit of exposure without knocking everybody out is what can lead to resistance. And we know there are many, many antibiotic resistant bugs out there, or germs out there now. So we have to be really, really sure that we're treating the germs with the right antibiotics for the right reason, for the right length of time, to reduce the chance that they'll develop resistance over time. And antibiotic resistance isn't so much, like you had an infection and you didn't take all your antibiotics and now you're going to get an infection with an antibiotic resistant bacteria. It's more the way bacteria are spread amongst people. It's actually a global issue. So, really thinking about protecting the health of our world and the effectiveness of antibiotics moving forward, we have to be really thoughtful about how we use them. So, remembering that our babies can get sick very, very fast. So we always want to intervene quickly if we think the baby's sick. But at the same time, if there's no evidence that there actually is an infection, once our tests start to come back, we need to stop those antibiotics. And that's really, really important. You may have heard the term antimicrobial stewardship. And this is really the important work that healthcare is doing to make sure there is responsible use of antibiotics around the world. And really, this is just to preserve the future effectiveness of the antibiotics, as well as protecting public health as we go forward. So it's not that nobody wants to give someone antibiotics. If you need them, you need them. But, there are certain infections that antibiotics are not going to help. So if the baby has a fungal infection, the baby has a type of yeast in their blood, they need an antifungal medication. They don't need an antibiotic. So antibiotics are not sort of the be all and the end all of keeping us healthy. So, how can your healthcare providers, or what do we do to help reduce the risk for your baby? Well, the first is hand hygiene. And I know you guys hear about this all the time, but this is really, really important. And so, depending on what products your institution uses, the layout of your NICU, there may be different sort of protocols for the way hand hygiene is done. But we know that the two main ways to reduce systemic infection in our babies, particularly associated with things like central lines and PICC lines, is hand hygiene, and the second is scrub the hub. And when I say scrub the hub, I'm talking about when your healthcare provider cleans the line before they put an injection into it. So whether that's a medication or whether a flushing of the line, they want to take any bacteria that's sitting on top of that port, and they want to get rid of it. So if you think about your baby lying in their little Huggy in their incubator, and let's say they have a PICC line in their arm, so a peripherally inserted central line, there's going to be at least one hub on it that they can give other medications through. And the baby moves around, in his bed, and that hub touches things. It touches his belly and it touches his sheets. And then I go in to change the diaper and I turn him over and it touches my hand. So those hubs aren't clean. So we have to clean them before we access them. So most places have a very similar scrub the hub protocol, which is 15 to 30 seconds using an appropriate type of swab, cleaning it, letting it dry, and then injecting whatever you need to inject in it without contaminating it. We also need to think about cleaning equipment. So if your baby's in an NICU where there's a lot of shared equipment, if somebody has a stethoscope around their neck and they look after this baby and then they go to the next baby, that stethoscope needs to be cleaned before it's placed on baby number 2, because otherwise it's taking bacteria from baby number 1 and potentially moving it to baby number 2. If we are sharing kangaroo care chairs, if we are sharing breast pumps, if we bring the glucometer to check a baby's blood sugar into one baby's space and then take it out and take it to another baby's space, all of these things should be cleaned in between that change. For us as a healthcare team, it's very important that we identify problems early and interact or intervene appropriately. So anytime we think a baby isn't well, your babies don't have the ability to tell us what's wrong. They don't have the ability to say, we can generally recognize that they're in pain, but they can't say my pain is I have a headache or my arm hurts or my belly hurts. And they only have so many ways to tell us they're not okay. And they're kind of all the same. So the symptoms for one thing are very, very similar to the symptoms of the other. And so whenever a baby is acting poorly, we have to make a generalized assessment of, okay, is this because we changed the breathing support and she wasn't ready and she's getting tired and we need to escalate that breathing support again? Or is it that she's getting sick? Is it because we changed her feeds and she's not tolerating it? Or is it because she's getting sick? So a lot of times we have to make this assessment of what we think the problem might be. And if it's not clear, or if we think it might be one of 2 or 3 or 4 things, infection's always going to be one of them. And we're always going to intervene, which means we're going to do testing and we're going to start antibiotics until we know that it is or isn't an infection. I talked about your baby being exposed to a bunch of people. It's really important that staff don't come to work sick. And this is where leadership plays a huge role in supporting staff not coming to work sick. So this is very, very important. We have this little bit of a joke, like during orientation with our new nurses, that if we walk past you in the hall and you smell like Vicks, you're going home. Like don't try to fake it. We're here to protect the babies. Please don't come to work sick. And sometimes that means a staff member staying home and it turns out to be allergies, but it's always better safe than sorry. So we really want to make sure our staff are healthy and stay healthy and don't come to work when they're sick. During the pandemic, there was so much talk about PPE. So PPE is personal protective equipment, and this is masks, gowns, gloves, goggles, face shields, those sorts of things. Using that appropriately is really, really important. And it doesn't mean wearing it all the time, because there are times that it's appropriate to wear it and there's times that you don't have to. I don't ever want someone to feel like their baby has to be put in a bubble and protected from all the things in the world, because that's also not actually how they develop that immune system. They do need to be exposed to some things, but using PPE appropriately is important. So if we're doing a sterile procedure, then we want to be sterile. That's very important. We want to make sure we're not introducing bacteria into the baby's system. But generally speaking, if you see staff gowning and gloving, it's not generally to protect your baby. It's because something's happening there that we don't want to transfer to someone else. And again, it doesn't mean your baby's sick, but your baby might be colonized with a bacteria that isn't causing them any problems, but we want to make sure we don't move it to another baby. So using the right PPE is important, but also using it properly. So something that we saw a lot during the pandemic, not necessarily in an ICU, but around the world, was because there was such a shortage of PPE, things being reused when they were supposed to be single use only, or things like people putting hand sanitizer on gloves. So gloves are not meant to be cleaned. You put them on, you use them, you take them off. You clean your hands, you put on a new set. So things like that are really important to help protect our babies. Early and ideally exclusive human milk feeding will also reduce the risk of infection for our babies, not just because of the antibodies, but also because human milk is perfectly made for human babies. So whether that is express breast milk from a parent or whether that's the use of donor milk, these both of these things will have some antibodies in them. Donor milk will have less because generally it's pasteurized, which means some of the antibodies are killed off, and that's okay. But it's easier on the gut, helps keep the gut healthy, and that in itself will decrease the chance of infection. And then if we think about that healthy microbiome and the things we can do to help mature it and to help get those bugs where they're supposed to be, we can use probiotics and we can use something called oral immune therapy. So probiotics, again, often if you're given a prescription for antibiotics, your physician or NP will say, and you should probably take a probiotic. And that's because we're trying to build up again those germs that are supposed to be where they're supposed to be, pardon me, while those antibiotics are trying to knock them out. So probiotics are bacteria. It is little bacteria in capsules or in a liquid, but they're good bacteria. And they're the bacteria that's supposed to be, generally speaking, in your gastrointestinal tract. So you take those to try to build up how many are down there so that they can do their job. Oral immune therapy, in your hospital might call it something different. We call it OIT, is where we take little drops of expressed breast milk. And this is never donor milk. This is only fresh expressed breast milk from a parent. We put it inside the cheek, just a drop, multiple times a day. Generally speaking, this milk should never have been frozen. It can be refrigerated, but never frozen because, again, freezing milk can cause some of those antibodies not to be as effective. And helps absorb into and really quickly into the baby's system, as well as normal flora as well to help start making that immune system a little bit more robust and giving it that little boost. The other thing that is great about oral immune therapy is when you give a little taste of milk in the baby's mouth and then you offer the baby a soother so the baby sucks, and then maybe you give a tube feed, the baby's brain starts to make some really great connection of, oh, I taste milk, I'm sucking on something, and my tummy's getting full. So later, weeks down the road, when we're time to start orally feeding, their brain already has a little bit of that connection of, oh, when I get milk in my mouth and I suck, my tummy gets full. So now that there's a nipple presented to me, okay, I'm going to suck on that. Oh, I'm tasting milk. Oh, I know what this is going to lead to. So it sort of has a really nice two-prong approach. So that's how healthcare providers work to protect your baby. But what are some of the things you can do as parents? I'm going to talk about the first two here, and then in the following slides, I'll talk about the rest of them because I want to touch on each of these. You are your baby's number one people. You are the primary care providers. You are the constant in their lives. You are the most important people in their lives. And you are the people they're going to have the most contact with. So you need to do your best to stay healthy, particularly during cold and flu season. This is really challenging, particularly if you have other children at home, because we know kids are gross. They are germ factories. They go to school, they go to daycare, they go to the babysitters, they eat things at the park, they put everything in their mouth. They're sick all the time. So I am not saying you have to move your toddler out of the house while you have a preterm baby. What I'm saying is you need to be aware of things and do the things that are within your power to stay healthy. So this is eating well, staying hydrated, and sleeping. Those are the three biggest things you can do to try to stay healthy while your baby's in the NICU or shortly after your baby goes home. If you get sick, if you get the flu, if you get a cold, if you get pink eye, if you get chicken pox from your 2-year-old who went to daycare and somebody had sent their kid to daycare sick, you're not coming into the NICU to see your baby. And nobody wants that. So whatever you need to do to try to stay healthy is really, really impossible. So that might mean instituting a great hand washing campaign at home that everybody gets involved in. It might mean, recognizing that your 3-year-old's starting to look a little sniffly. So maybe we're not going to do a whole lot of face-to-face really closeness for the next little while. I don't actually know how to prevent that because I was never successful with my own children of trying to keep them out of my face or from coughing in my open mouth. But really, whatever you can do to try to stay healthy, because your baby in the NICU needs you to be healthy when you come see them. So this is really important. It also means being honest with yourself. If you don't feel well, The idea of not seeing your baby is not anything anybody wants to have, but really being honest with yourself and saying, I'm not sure if this is brewing, if this is a cold brewing or a virus brewing. Maybe I should stay home today and just rest and make sure, and hopefully tomorrow I'll be fine and I'll be able to go, to make sure you're not sick. So the second part of that is managing your visitors. Your baby is so loved, and the people in your life want to see your baby and want to have access to your baby and want to support you. But it's your job to, first of all, pass along the information about not visiting when they're sick and the importance of them staying healthy. But this can be really hard. If grandma is desperate to see the baby, it can be really hard to tell her she's not allowed to come in because she was visiting Aunt Susie yesterday, and Aunt Susie today has now been diagnosed with COVID. So it can be really, really hard. But as you are your baby's number one safety officer. So you really need to ask the questions when someone says they want to come see your baby. How are you feeling today? Have you been around anyone that's sick? Is anyone in your house sick? And if they don't seem well, you need to speak up and you need to say, out you go, you can't be here. And that can be really, really hard to do. Generally speaking, the closer someone is to the baby, the more worried they are about the baby. And it tends to be the people that don't have a great understanding of the situation that are like, oh, it's fine. You know what I mean? I'm sure I'm not sick. It's probably just allergies. I just won't say anything. Generally speaking, though, if you can educate people and you can share the information, then people will respect that. Something that we always say, and I'm sure that people in other hospitals say, is make us the bad guy. If someone is not really listening or someone is giving you a hard time, make us the bad guy. Tell them it's us. Tell them we say they can't come in, or that the baby's not allowed to have visitors this week, or whatever it may be. We're always happy. We will back you up. I've never known a nurse to contradict a parent if the parent's using them to be the bad guy to with extended family and friends. So we are always happy to be the bad guy for you if it's needed. So let's talk about when you should be doing hand hygiene, because that was all right, the next one, hand hygiene. So when should you be doing hand hygiene? This is really, really important. When you arrive to the hospital and you're in your baby's room or your baby's bed space and you take off your coat, you hang up your bag, and you're dealing with your express breast milk and whatever that may be, you need to clean your hands once you've done all of those things. So once you've taken all your outside clothing off, that sort of thing, clean your hands. Should be pretty clear. Clean your hands before you touch your baby. Very important to be cleaning hands after a diaper change. And this is something that when you're sort of in the role of all the things you have to do, just make it part of your routine. When we talk about hand hygiene, we're talking about two different things, two potential options. One is washing your hands with soap and water, and the other is using hand sanitizer or an alcohol-based hand rinse. Generally speaking, hand sanitizer is your better go-to for a quick cleaning of your hands. However, if your hands are soiled in any way you can't use hand sanitizer, you need to wash with soap and water. If you think about it as if you were dealing with raw chicken and you had raw chicken juice all over your hands, you wouldn't just go pump and put some hand sanitizer on and clean your hands that way. You would go and wash them with soap and water. So this is particularly important with diaper changes. If baby pees on you, if you get poop on your hand, you need to wash your hands with soap and water. So make sure your baby is in a safe space. So if you're in the hospital, whether that's closing the porthole doors, putting the side of the crib up, walk, clean your hands, come back. Once you're at home, making sure your baby's not left on a surface unattended, but making sure you're cleaning your hands as quickly as you can after you change a diaper. The other things to think about are pumping and preparing feeds. So if you have just sterilized your entire pump kit and you're about to kind of like put everything back together, ready for your next pumping, make sure you clean your hands. When you're ready to pump, you've got everything together, you're sitting down to pump, make sure you clean your hands. What I want you to think about is, let's say you've gone to the bathroom and maybe you didn't clean your hands quite as well as you should have. And now you're touching all your pump parts, or you're mixing formula, or you're touching your baby's bottles and preparing a feed, and the germs from the bathroom are still on your hands. Those germs can get into your baby's feeds. And that's this idea of particularly something like E. coli. E. coli is meant to be in your intestines. It's not meant to be ingested through your mouth. And this can lead to the baby getting sick. So really, really important that you are not dealing with your baby's food or what will become your baby's food or what touches your baby's food without clean hands. This is very, very important. And it's particularly important if you have someone that's helping you. So let's say your partner is taking care of your pump for you or is making feeds while you're changing the diaper, making sure that your partner also understands the importance of don't be touching the pump kit, don't be putting the bottles together unless your hands are clean before you start. So we've talked a little bit about the antibodies that are passed through breast milk. We've talked about OIT and how it helps, but we're also going to talk about skin to skin. So skin to skin has so many benefits for your baby. And that I'm sure there's whole Preemie chats just about skin to skin. But skin to skin, so we know skin to skin helps with brain development, it helps with bonding, it helps with all of those sorts of things. But it also is one of the best things you can do to help infection as well. And this is where science is really cool and the human body is really cool. And I find this fascinating. So we've talked about how your baby is in this really germy environment. Hospitals are gross. So your baby's in this environment and his environment's germs are on him, let's say, for lack of a better term. When we take that baby out and we put that baby on you, or when you put your hands on your baby, your nice, robust immune system gets exposed to your baby's germs. And your immune system says, oh, those things are no good. I'm going to mount a defense. I'm going to make some antibodies. And sorry, I should specify skin to skin to prevent as a method to help reduce the risk of infection is specific to the parent that's producing milk. Skin to skin for the other parent is also just as important, but it doesn't play a role in infection prevention. But it has so many important roles of brain development and bonding and things like that. So we are specifically speaking about someone that is producing breast milk. What happens is your body mounts a response to the germs your baby's being exposed to because now you're being exposed to them. And then those antibodies pass into your breast milk. You pump your breast milk. You feed that to your baby. And so your baby gets those antibodies to his own germy environment because your body mounts a response to them. So that is, to me, something that is really, really cool. And this is why we say any amount of breast milk is better than none. So if you are only able to produce enough to give OIT, amazing. If you're only able to produce some for a few days or a few weeks, amazing. If you're unable to produce breast milk or to provide breast milk for your baby, then generally speaking, most NICUs now will have access to donor milk and things like that. But we recognize that there are things that might be out of your control. But this is why we encourage families to provide as much breast milk as they can, even if it's just a little bit and even if it's just for a little bit of time. We also recognize there may be factors at play that limit how much time you're able to spend with your baby. So in a perfect world, you would be kangaroo carrying or skin to skin. That baby would be on his or her parents the majority of a day, but we know that's not realistic for most people. So if there are factors at play that limit how much time you have with your baby or how often you can see with your baby, then we want you to make skin to skin a priority. If you can only come for 1 hour a day, then try to plan it so that 1 hour your baby can be on you or your hands can be on your baby. If you can only come once a week because you live very, very far away and your baby's been transferred to another hospital, then prioritize getting skin to skin time when you're together because it's so important for the baby. All right. So I talk about being an advocate and asking questions about your baby and what's happening. Really, it's really, really important that you not be shy and you not be scared to work with your team and you don't be scared to ask questions. There is nothing that a parent can ask me that I will be upset that they're asking me. So if you're feeling nervous, then you can sort of go the little sideways way where you're like, oh, here's some hand sanitizer for you as you see someone going to your bed space. If you see someone come in with a stethoscope around their neck and they immediately, like maybe they clean their hand perfectly and they go to take it off and put it on your baby, you say, "Oh, would you mind cleaning that before you use it on my baby, please?" And generally speaking, I hope the response is, "Oh, of course. I'm so sorry. I forgot," or whatever it may be. But if you think a step has been missed, then ask, "Did you scrub the hub? I didn't see you take any alcohol swabs." Or if you think someone is sick when they come into the room, call them on it. No one is going to be angry with you for asking the questions about protecting your baby. If someone else has done something where you feel like, let's say your nurse has changed the baby's diaper, and looks like maybe they're going to like just kind of move on with the rest of their care, you can say, "Oh, I'll stand here by the open portholes while you go wash your hands." If you think someone is sick and they maybe deny it, or you're not comfortable saying something to them, you can always go, for example, to the team leaders, so the charge nurse, and say, "I'm a little bit worried that my nurse today is sick. She seems very snuffly," or he, is sneezing a lot. Like, do I have something to be worried about? And they should intervene. Or if you're concerned that a consultant has come in, maybe from another area in the hospital, and they're not cleaning their hands, you have a responsibility if you see something, you say something. First of all, it'll eat you up alive if you go home that night and you think, "I don't think that person cleaned their hands and I didn't say anything." So we don't want that. We don't want you stressing about that later, but also you're trying to protect your baby. So no one should be offended or worried or upset that you question what they're doing, because we're all in this for the same reason. We're all there to protect your baby. Also, if people are doing the things they're supposed to be doing, they shouldn't be offended if you ask them if they did it. I know that there can be a lot of different personalities in the NICU in any workplace, but really, you are your baby's number one safety officer. You are kind of like their case manager. You should have a good idea of what's happening in general. And if you're a healthcare provider and a parent asks you, we need to remember it's your job to protect your baby. So, of course, you're going to ask me these questions. So, I never want you to be scared to ask your team. And as the team, I never want the team to be offended, because it could be they just didn't see you. So if somebody says to you, "Excuse me, could you clean that?" "Oh, I just did." Right? "Oh, you were putting your pump kit together. I cleaned it." And really, in the grand scheme of things, clean it again if it makes the parents feel better. This is very, very important. As the parent, you have the best sort of finger on the pulse of what's happening with your baby. You spend the most time looking at your baby. You know your baby best. And you may not feel like that at the beginning, but over time, you absolutely know your baby best. Healthcare teams come and go. At Sunnybrook, we have 200 nurses. So on any given day, you may have someone who's never met your baby before, doesn't know your baby's patterns, doesn't know what's normal for your baby. So really, it's important that if you think something's up, that you say something to someone. "Jimmy doesn't seem himself today. He seems really tired," or "He seems really cranky," or "I can't put my finger on it, but something's different." The staff will listen to you, because we know that you have a great understanding of what's normal for your baby. Generally speaking, if a parent says, "I'm not happy, my baby's something's wrong," we start looking for things. And that's often why we find things really, really early. And the earlier we find something wrong with the baby, the earlier we can intervene. So please, please, please never be scared to say, "I think there's something wrong." So, what happens when you go home? So it's all fine and good to talk about all of these things in the hospital, but then you go home where you're by yourselves, and you may have a whole spectrum of how complicated your baby is when your baby goes home, and whether there's diagnoses and medications, or whether your baby's had a really smooth course and comes home with nothing extra, maybe some extra vitamins and some extra calories in his feed, and a couple extra doctor's appointments, and you can kind of fall anywhere in between. So how do we keep our babies safe when we go home while still trying to have a life? Because you need to have a life, and you need to find joy in the fact that your baby is now home with you. So the first is hand hygiene. That doesn't change. Keep cleaning your hands. That doesn't mean every time you pick your baby up, you have to clean your hands. But think about the key moments: feeding, diapers, gross stuff outside, cooking with the raw chicken. Keep your hands clean. I don't want you to be scared to pick up your crying baby because you didn't clean your hands. The second is consider limiting visitors or screening your visitors, particularly if your baby goes home or is small during cold and flu season. There is nothing wrong with saying, we're not having anybody come over, or making sure people are healthy and asking the questions and saying, no, you can't come if you're sick. For many of our families, particularly if their baby was very early or very sick, you may want to consider delaying large get-togethers. This is particularly challenging if a baby goes home right around a big holiday where everyone's like, great, you can bring him to the Christmas party. Oh, he'll be home for Hanukkah. You know, this is something that causes so much stress for parents. So consider delaying large get-togethers where people are going to try and play past the baby. Or if you do have a large get-together, consider baby wearing. If you put that baby in a nice wrap on your chest, people can take a peek, but you're not playing past the baby. If you are allowing people to hold your baby, and you don't have to allow this because this is your baby, you get to say no. Consider some ground rules. If you want to kiss the baby, you can kiss his feet. No kissing hands, no kissing faces. Or, these people can hold the baby, but we're not doing past the baby, like the neighbor's second cousin down the road who's here at this party who I don't know is not holding my baby. And don't worry about people thinking you're mean. It's not about them. And it's not about you. It's about your baby. So are you upset? Are you worried about upsetting great Aunt Susie? Right now, it probably doesn't matter. What matters is keeping your baby safe. So think about those things. And then keeping that, I don't want to say vigilance because I don't want you to be like on this heightened awareness, but you already are. But keep track of the basics. How well is your baby feeding? How well is your baby peeing, pooping, sleeping? Generally, do they seem right? And if you're worried, say something, right? Put your hand up, call your dog, call your NP and say, he's not peeing. Something's up. Like his food's going in, nothing's coming out. Something's up. So just like you would have done in the hospital, you want to make sure that you're doing those things to keep the baby safe. There's all sorts of tips and tricks out there too. If you look on like Preemie boards and things like that about, little signs that go in the car seat that say, I was a preemie, please don't touch, or things like that. Because the general public is crazy because people think babies are free range and, there's a baby at the superstore and I'm going to go tickle it. Like, why are you touching a stranger's baby? I don't understand. So there are different things you can do as well, but those are really the biggest things, and try to find balance. This is so important. You want to keep your baby safe. You want to be vigilant, but you need to find joy. You are home. You need to get into as normal a routine as you can. And your normal might be different than someone else's normal whose baby was full term. Or it might be different than the normal from the parent friends you made from the room next door whose babies, was also preterm, because every family is different. Every situation is different. Every course that their baby has is different. And your new normal might involve lots of appointments or medications or oxygen at home or whatever those things may be. But you need to find balance, you need to find routine, and you need to find joy with your baby. Thank you so much for having me. I hope that you found this interesting. And I'm happy if anyone has any questions, I'm happy to answer them.
Thank you so much for that. Wow, lots of information in there, lots of good information.
Way more than I thought I was going to.
But you know what? The thing that I appreciate about your presentations is that it's always in everyday language and it's just very real. And so I appreciate that. I could listen to you talk about this kind of stuff all day. It's great. But I'm wondering, I do think you're a little different, Meghan. I hate to say that about you, but when I think about the awkwardness, I guess, of myself as a NICU parent and a lot of families in NICU, I think, and I was very protective of Tessa. I definitely turned away visitors. And there were family members who we had that discussion about how they were feeling. But talking to healthcare providers is a whole other realm that I don't think we've mastered yet in NICU.
I think that, I do actually think that sometimes we have like two ends of a spectrum. We have the parents that won't say anything. It doesn't matter how uncomfortable they are. They're too scared to say anything, or they don't feel supported to say anything. And then on the other end of the spectrum, we have parents that struggle so much with the lack of control that they try to grasp onto controlling every single aspect, and sometimes get the label of being a challenging family, right? Or a high needs family. And what we need to find is somewhere in the middle, right? So it breaks my heart when families are on either end of the spectrum, because I don't know if a family's not asking me questions because they actually don't have any questions and I've done a good job of explaining things, or if because they're too scared to ask me.
Mm.
Um, but it also breaks my heart when a family is in such crisis that they feel like they have to micromanage like every
Right.
little possible thing. Because as a parent, that's what you're supposed to do. Every single decision is supposed to be yours. You decide when your baby eats and sleeps and what they wear. And now suddenly you have these strangers telling you what's happening with your baby. So
Right.
it breaks my heart when anyone's on either end of that spectrum. Um, I think, though, that building trust is huge. And we've heard from some parents where maybe they've made a complaint about a nurse. Often it's let's say a nurse or an RT or a physician, it doesn't matter. Sometimes it's not when something first happens, it's after like multiple things have happened that have upset the
Mm.
family. And so sometimes we'll say like, why didn't you say something the first time? And it's generally because they're scared their baby's not going to get good care if they complain.
Mhm.
And that to me is terrible. That's a terrible feeling for a family to have. And I say with as much certainty as I can that every single healthcare professional I have ever known would never take out anger or displeasure on a family, on their baby. So
Mm.
I personally really feel like that's an unfounded fear because we're all there to take care of the babies. If the parents are challenging to that particular healthcare professional, they're not having a good relationship, they haven't connected well, whatever that may be, that is separate from the baby. And so I'd never want a family to not say something because they're scared their baby's care is going to be affected. Because that
Mhm.
should 100%, like, I don't like to talk in absolutes because every hospital is different, every healthcare provider, but that 100% should not happen. But it's
Mhm.
a fear that families have. I'm here 4 hours a day. That's 20 hours a day. I'm not. Are they going to take good care of my baby, or are they not because they're mad at me?
Right.
But you're right. It is really, really hard. And I think that um, even for me, I I'm generally an open book. I feel comfortable 24 years that, I wasn't like this at the beginning. I'm not uncomfortable admitting I don't know something, that I don't have the answer, or I don't know why we're doing something. I'll say, "Oh, actually that's a really great question. No one's ever asked me that before. Let me see what I can find out." Or, "I'm not sure the best way to explain this. I might not be the best person to explain this to. Let me go get the pharmacist." I have no problem doing that, but particularly for junior nurses, and I'm speaking nurses because that's what I am,
Mhm.
but junior staff in general, they might feel really threatened when they're questioned. And generally speaking, I always try to make sure people understand that when you're questioned, it's not because someone is challenging you, it's because someone doesn't know something. So it's our
Mhm.
job to educate them. So my number one job is to look after this little tiny person in this incubator. And my very, very close second job is to take care of the family. And so to me, you come together. It's either as a parent, you're either part of my patient or you're part of my healthcare team.
Mm.
And that is something particularly at Sunnybrook that we really try to push because parents are not visitors, they're parents. So either I'm nursing your baby and I'm nursing you at the same time. I don't want to see your C-section scar though. Don't show me your weeping infected wound. That's a little different. But generally speaking, I'm just as concerned about you as I am about your baby, or
Right.
maybe like one half step below, or we're working together to keep your baby well. And so whatever way we can support our staff to be open to families, to taking questions, to not getting offended, to
Mhm.
not thinking they're being challenged, to not walk in with a chip on their shoulder, that's really, really important. But it is really hard. And I'll be honest, it's been particularly more hard post pandemic
Mm.
because of just the global change in the way that people interact with the healthcare system and the experts
Right.
from their internet searches. Like that whole thing kind of exploded in a way that no one I think ever saw coming. And so there's a lot of healthcare providers that are kind of like this already every day, like, you
Right.
know. Um, so it's really a matter of trying to help build the confidence of our healthcare providers so that families feel comfortable questioning things.
Mm.
But at the end of the day, own it. Oh, I say own it. Ask the questions. Did you? Why are you? Can you explain? Right? And if you have a concern, you need to speak up. So, because if let's say you didn't ask, and let's say your baby got sick, and not to say that those two things were related, the
Right.
whatever the thing you were asking about and the fact that your baby got sick may have nothing to do with each other, but you'll always question and you'll always wonder because that's what we do as parents. We
Mhm.
wonder what could we have done differently, What could I have done in the small little bit of this that I can control? Where did I screw up? Because we're really,
Mhm.
really good at blaming ourselves. And I don't know what that is. That's something biological and it's terrible and I don't like it. And, my kids are almost 13 and 15 and a half, and I still do it. I'm still like, is she acting this way because I didn't let her sleep with her soother till she was 3? There's always something that you question as a parent. And there's so much going on when your baby's in the NICU. We don't want to add to
Mhm.
that. So
Mhm.
you build a trusting relationship with your healthcare team where you can say, hey, oh, I noticed the hand sanitizer is empty. Would you like me to grab another one when I go to the bathroom? I don't know. There's
Mhm.
ways you can say things. Um, you know, I say be direct, don't be passive aggressive. You can be passive aggressive adjacent with the whole here's some hand sanitizer. Let me pass that to you. Oh, let me get you a clean whatever because you just dropped that on the floor. Um, but there has to be some trust,
Mhm.
and that trust works for when you're not there, but it also works so that you feel that you can talk to your team.
I appreciate what you're saying about laying blame and even how you started your whole presentation.
Mm,
I was like, yes, that is such a freeing thing of how you set the stage, because I think you're right. So many people go through all those scenarios, all
mhm,
those steps. And when you think of your baby being sick in addition to being premature, then it is that kind of cycle of guilt
mhm.
and blame. And so I
Ah,
appreciated how you
especially
started.
when the guilt you may already have about the fact they even came early,
Right.
right? Like that you failed at your job as the
Yeah.
person carrying the pregnancy, like, and then
Yeah.
you just add to it because we're really, really good at that. And so we don't want to add to that. And as your
Mhm.
team, we shouldn't be adding to that. So we should be educating you and then also following those same guidelines ourselves. And again, there I can say with confidence, there's no one out there that is looking to cause harm, that is doing
Mhm.
something because they know it's bad and they don't care. No one is doing that. But generally speaking, we're busy. People have a lot on their minds. They might forget, did I clean my hands? Did I not clean my hands? Or there might be a lack of education. You never know. It could be
Mhm.
an ignorance thing. And so, depending on where someone has come from in the world and what kind of practices they had, maybe they're a visiting physician who's now learning here, and they may have different practices because their resources are different. And what is normal and acceptable there because they have no other choice. If they're coming from somewhere where, the needles we use to poke for an IV are scarce, they may use the same needle more than once, whereas we don't because we don't have that. But we have to teach them. We have to say, oh no,
Mhm.
we don't do that here. This is how we do it here. Um, and again, it's not because this person doesn't care that's we consider that to be an unsafe practice. It's just because where they come from, it's the only practice, the only option they have.
Mm.
So really, it's about kind of all being on the same page and how do we do that. But you're right, it can be really hard.
We are out of time for today, but I appreciate all of the information you provided today, all of the authenticity of, again, those difficult questions, and just, giving both sides as well, that it really is that team mentality of everybody working together to keep our babies safe and healthy. So thank you so much for
Well,
sharing with
thank you
us.
for having me. It was my pleasure.
And thank you, everybody, for joining us here today for today's episode of Preemie Chats. A special thank you to AstraZeneca for their ongoing support of educational programs such as this one. Just a reminder that if you missed part of today's episode, or if you want to rewatch it, or see any of the past over 300 Preemie Chat episodes that are available, you can go to CanadianPreemies.org. Again, that's our website. You'll want to go there to see all those past episodes, to see all of the resources and support that are available for you and for your NICU. And you'll be reminded while you're there that CPBF is a charitable organization, and it really does depend on support to continue its important work. So while you're there on the website, you may want to think about how you fit into that support and how you can help CPBF in its mission to empower families of premature babies in every step of their journey. Together, we can create a brighter future for all preemies and their families. I hope that you'll join us here next Friday at 1 p.m. Eastern Time as we discuss PPROM, the preterm premature rupture of membranes, and we'll look at key strategies for management, future research, and supporting future pregnancies. You'll also want to mark your calendars for October 8th. We're going to have our next scientific preemie chat, and that's where we're going to be talking about the different ways we manage BPD, because there isn't a clear path with something like that. And so we're going to hear multiple perspectives. I hope you'll join us on October 8th for that. In the meantime, thank you for joining us today, and I hope that you all have a good, quiet weekend.